welcome back to Style Points. We've decided to skip the RSI for this episode. Some of the subject matter today is a little heavy. Today, I'll be talking with my friend Mary Roberts, who did her anesthesia residency and OB fellowship here at the University of Cincinnati. Let's jump right in. I just sent this to you. I feel like I should be able to find it more easily. Here we go.
You go to your sent email. I'm just kidding.
This isn't helpful.
You're welcome.
Just because you're married to one of the podcast hosts doesn't mean that you can harass me the whole time.
No, I thought that was because we're friends. I can harass you.
Okay, that's also fair. Mary, thank you so much for joining us.
Thank you for having me.
One of the benefits that I have as a podcast producer is that I get to ask all of my friends to come join me on the podcast. And you are somebody that I've been trying to get to come on the podcast for a really long time because you are one of my close friends. You also happen to be married to my podcast co-host, Nate Moore.
That is true.
So my first question for you is, what took you so long to come on the podcast?
Ooh, that's a tough question. And I have two separate answers. One is because my husband is a co-host on the podcast. It's his and your domain. And so, we work together a lot. My husband and I, we're both anesthesiologists, but we each have our own kind of roles as anesthesiologists, and we don't always cross over. We do sometimes, and it's a lot of fun. But, this is his and your thing, and I think that's awesome, but not my thing. The other reason is I just don't like to hear my voice. It sounds kind of weird. So
I guess what I'm hoping for after this is that you're going to be approached by all of the people who listen to the podcast, and they will tell you that your voice does not, in fact, sound weird, because it just sounds like your voice to me.
Oh, good.
Let me start out with the who you would go out to dinner with question. So if you had the chance to go out to dinner with anyone in the world, it could be somebody from the past or even from fiction, who would you go out to dinner with and why?
So my immediate answer is my daughter Alice, but I don't want to skip forward in talking about that. But that would be my answer. Is I want to go to dinner with my daughter.
I think that it's fair that we don't want to skip ahead, but I think that is a reasonable preview. Before we get into that, and maybe we can talk more about why that is a little bit later, let's talk about OB anesthesia. That's what you did your fellowship in. That's your specialty. What drew you originally to OB anesthesia?
I think there were a couple things that drew me to OB anesthesia. As a CA1 resident, I was first introduced to OB anesthesia outside of little things I'd done as a med student. But my first true exposure was a CA1, and I was not expecting to love it as much as I do, which is interesting looking back on it because I feel like now I couldn't see not doing it. But when I started doing OB anesthesia, I really enjoyed the patient interactions. I enjoyed being there for that special moment in my patients' lives, whether it was a good moment or a bad moment. It felt very special to be a part of it and to help ease their pain or help them through this moment. Because even though it's a very special moment, it can be a very stressful moment. Again, good or bad outcomes, it can be a stressful moment. And so being there and being able to help them through that is an amazing gift that we are given as OB anesthesiologists. And then, of course, I also liked working with my hands, being able to help with pain control, seeing immediate gratification from taking away their pain with epidurals, spinals, and taking care of two patients at once or more than two patients at once. It's very uncommon that we're in a situation where what we give one patient actually affects another human being so directly, because that human being's still inside mom.
So I also enjoy OB anesthesia for the same reasons. And one of the things that I think about, especially on OB, is communication and how that communication matters in those special moments or those stressful moments, right? When you are talking to laboring patients for the first time, what are the things that you try to communicate with them so that they feel safe and comfortable with you?
Yeah, I think one thing I do, and it's not specifically saying anything, it's just asking them about themselves or their baby or anything even in the room that I have an opportunity to almost latch on to show them that I care about them as a person and not just a patient. Establishing that rapport with them can go a really long way so that when you're talking to them throughout their experience, they know that you're seeing them as them and what they're experiencing and not just another patient. And so it's can be something simple like, "Oh, I really like your nails," or "Oh, I see you have a Reds cap on. I like the Reds too. Too bad they're really bad this season." um, just having those moments, or even just saying, you know, "Tell me about who's with you today," or um, "Tell me about your baby," or something, to establish that connection with them on a more like human level.
So you supervise a lot of trainees. Education is something that you do a lot of. Are there phrases that people tend to use on OB that you don't think are super helpful?
I do think that phrasing things is extremely important when it comes to talking with patients. One thing that I find frustrating from my perspective, but I know everyone's a little different, is when you have a patient who's not English speaking talking to the interpreter instead of talking to the patient. Can be very frustrating, from my standpoint, because I feel like, yes, they don't understand you, but even just saying things to the patient and looking at them when you're talking can be meaningful, even if they don't understand the words you're saying.
I heard something the other day that kind of stuck with me that reminds me of, which is that something like 80% of communication is nonverbal. And so that certainly matches up with that. I try to be really intentional when I'm using interpreters as well to make sure that I'm looking at the patient, that I'm uh, doing all of the same facial movements that I would do if the patient understood me so that they can get a sense for what I mean and how I mean it.
Absolutely. And I think that's really important when you have that communication barrier, that language barrier. It doesn't have to be a full communication barrier. Um, you can still communicate with the patient in ways that are not, direct spoken language. Um, so I think that's really, really meaningful.
So, one of the things that makes it tricky to do OB anesthesia is we do get to take away pain with spinals and epidurals, neuraxial anesthesia, but we actually have to cause people pain by placing those things before we can relieve that pain. And that can sometimes be a really anxious moment for people. So, how do you explain to patients what they're about to feel that makes it maybe a little bit less scary for them? Because I know that there are a lot of people who are very afraid of an epidural. It's a needle that's going into your back.
Yeah, absolutely. I think the best thing to do is to try to normalize things as much as possible. So everyone experiences labor, delivery, epidurals differently. And so there's a whole range of what's normal, but kind of walking them through what to expect, and even relating it to experiences they may have had in the past, and using specific language. Like when you're pressing on someone's back, I say I'm going to press on your back. I don't say I'm going to touch your back. I'm not saying I'm going to push on your back, because one sounds a little too aggressive and one sounds maybe too light. But saying pressing on your back, that's what I expect them to feel. Or when I'm numbing them, relating it to, say, have you ever had a tooth numb during a procedure? That's the kind of numbing that you're going to feel before we insert the needle to put the catheter in. We're going to numb it up first, just like we numb up a tooth. So it's something that they may have experienced before and they can relate to. Or if they haven't had that before, saying things more like a pinch and a burn or a numbing shot, not we're going to inject medication or do anything aggressive, but just trying to not downplay it too much, but also not overplay it either. And then also, again, normalizing different experiences. So you may feel a shock down your leg. It might feel a little bit like a funny bone feeling. Again, a normal sensation that they probably can relate to. Um, but then I also say, but you may not feel that, and that's also normal. Because I don't want them to say, I didn't feel it, or, oh, yeah, I did feel it. Both are normal. And so giving them that expectation, but then also saying, but you're not strange if you don't feel it, or you're not, it doesn't mean it's not working just because you did or did not feel that.
Sometimes on OB anesthesia, we get patients that are extremely anxious or on the verge of a panic attack when they come to us. And that can be for a variety of reasons. They could be their social situation that they're dealing with, it could be an anxiety problem that they're dealing with. When patients have that extreme heightened anxiety that we see on OB, what are some of the ways that you treat them differently such that you're taking the best care of them that you can?
So people have all different levels of anxiety coming into a delivery. And like you said, it could be for a variety of reasons. Maybe the last delivery didn't go well, or maybe they're just anxious about things, or maybe there's a social component, like you said. But listening to them and to why they're anxious, what they're anxious about, because it could be the C-section or it could be the epidural or it could be both. It could be a variety of reasons. So listening to that and then again normalizing it, like very normal to feel anxious about these things. That's okay. That is honestly expected that you're going to be anxious about these things. But we're going to take good care of you and we're going to do the best we can for you. Um so not trying to be, override their anxiety or say, that's okay. It's all good. It's all fine. That's not what we're trying to do. You want to recognize their apprehension, their feelings, but then say, you know, we're going to be here for you. And then also reading the patient. It's hard to do sometimes, but is this a patient who's going to do well with a joke or a distraction? If you guys just start talking about baby, or maybe that's not the right thing to talk about. Everyone's different, but recognizing something that can help them feel more comfortable, take their mind off it, or maybe they don't want their mind taken off it and they just want you to walk them through everything. That's okay too. But just trying to gauge what that patient needs in that moment.
One of my favorite lines that I use on patients that I have deemed appropriate that are feeling very anxious is I will say something like, well, we've never dealt with any anxious patients before, so this will be my first time, but we're going to try to get through it. And
Yeah.
a lot of patients have to think about it for about a second, but then it helps them relax knowing that I'm obviously joking. And then they also get to think, you know, this guy deals with patients who are anxious all the time. And that's why he's telling this joke. I think sometimes that can be helpful.
Yeah. Sometimes that can ease the tension. Um, a joke I like to do sometimes is people say, "Oh, I'm scared of needles," and I say, "I love needles, just not when they're pointed at me."
Oh, sure.
You
Yeah.
know, so then you're saying, I could be scared of needles too. I'm just they're not pointing at me, so I don't, I don't care. But it's just kind of levity to the situation, which is helpful.
So, another situation that we deal with a lot in OB anesthesia is walking people through what they're going to be feeling in a C section. Um, how do you set expectations for those patients to try to help them get through that scenario?
Again, I think everyone feels pressure, pain differently. Pain is an interpretation. It's not a yes or no thing. There are different levels of pain. There are different experiences that are interpreted as pain. Just because you've numbed someone doesn't mean they're not feeling pain. If you've ever had a tooth numbed and pulled, pulling the tooth still hurts. It's just that it's not a sharp pain. You're not feeling the pain receptors anymore. But pressure can still be very intense and very uncomfortable. And so, talking to patients and telling them ahead of time before they're feeling this pain, um, what to expect. Like, okay, you're numb, you shouldn't feel any pain. However, you might still feel pressure. And actually, the pressure can get really intense, but then turn it around. The pressure can be really intense right before baby's delivered, but that's a really good sign because that means baby's almost here, which is really exciting. Or maybe it's not exciting for them, but just say, which means it's almost over. Something to help ease them to so that they're still expecting it. It's not a surprise in any way, but still not overplaying it either.
So, one thing that we will often do after spinals and epidurals is something called checking a level. Can you briefly explain what that is for people and then how you like to do it to get the best information that you can?
Yeah. So checking a level basically is um, a test that we do to determine how high the numbness has gotten on an individual after they've gotten their epidural or spinal. And for a C section, for example, we want it to be about mid nipple line. So about what we say T4 dermatomal level. And so we'll check different levels of the skin height starting on the leg and working our way up and determine where our numbness is. Now, I gave a specific level for numbness, but numbness is actually a gradient because pain level will be higher than touch. Like I said, I still expect them to feel touch and pressure, which is a different level from motor. Everything has a different level, but what I want to see is where our pain level is. And so, what we often do is we use a sharp, but not too sharp implement to check to see if they're feeling like a poking sensation.
Kind of like the end of a paper clip.
Yes. It if it feels more like the tip of your finger, that would be a more dull sensation. But if it feels like a pokiness like the end of a paperclip, that would be the sharper sensation that we're looking for. Um, this can be really tough because again, people might feel it, but can't tell us if it's sharp or not. So oftentimes we'll start on the arm, which we expect not to be numb and to feel quote unquote sharp. And then say, does it feel the same as we work our way up from leg all the way up to again arm? Another thing we can do is to check temperature because your temperature sensation goes away with your pain. So you can check to see if something feels cold. It might not feel cold until you again get to where you would feel sharp pain. And so you can check and see, does this feel cold? And it's an ice cube. And of course, it's going to feel cold, except if they're numb. So one is not necessarily better than the other, but both work well on different patients and how they respond to your questions.
That makes a lot of sense. So, let's talk about when patients might start feeling a big sensation during a C section. Obviously, it's very important to us to make sure that our patients are getting through things safely and comfortably. But a lot of times, things can be misinterpreted as pain when it's actually pressure, or it could be real pain that we don't want to ignore. How do you approach those situations to tell what's what? And how do you treat those patients?
Yeah. So when a patient says that they're feeling pressure or they're feeling pain or they're feeling uncomfortable, any of those words, even if they just grimace and they're not voicing it to you, but they're showing you signs that they're uncomfortable during their C section, it's important to delve further into what they're truly feeling. Now, some of them will say, I don't know, which basically just means that the pressure or discomfort is so intense that they really can't parse it out, which to me may not be pain, but for them it's intense enough to feel like pain and probably should be treated in one way or another because they're at that level of discomfort. But a lot of times they can tell you, oh, yeah, it's just pressure, it just feels a little uncomfortable. Um, or they'll say, "Oh no, I'm feeling pain. It feels sharp. It feels like a knife. It feels," and then that's a sign that the numbness is not where you think it's going to be or where you think it is. And that maybe your epidural or spinal is not working adequately. Now, even an epidural that is quote unquote working normally, if they're still feeling pressure that's that intense, maybe they do need supplementation. And it doesn't mean that the epidural, doesn't have a good level. But in some sense, it is a bit of a failure of the epidural because it's not keeping them completely comfortable and they do need supplementation or even conversion to general anesthesia. And so that needs to be a constant communication with the patient, telling them that you hear them, asking them how they're feeling, and seeing what you can do to help them through that moment or the rest of the surgery.
Yeah, I think it's a very individualized thing too. And I
Absolutely.
think you have to connect empathetically with the patient, look at their face, and try to ask yourself, do you think that this patient is going to be able to get through this with enough comfort for it to be acceptable or appropriate? Or do we think that we need to do something about it? But it's also tricky because whatever we give to mom also goes to baby for the most part. So whenever we give mom a pain medicine, it can affect how the baby's breathing when it comes out from the C section, too. So it can be really tricky.
Absolutely. It's definitely a balance of making sure that mom is comfortable, but then also making sure that baby is safe because that will impact mom and baby's experience as well.
So, shifting gears a little bit, back when you were in your OB fellowship, that is when you became pregnant for the first time. Is that right?
Yes.
Can you walk me through what that time was like for you?
Um, it was mostly anxiety provoking because I could see all the complications that we deal with on OB, and that was very scary. It was also very exciting, and it was neat to be able to relate to patients on a new level. Like, not just, hey, I kind of, by in theory, understand what you're going through, to, oh no, I'm actually there and I'm experiencing things as well, being able to relate on that new level with patients. I think in medicine we often see the complications, which is why again it can be anxiety provoking. But as time progressed through that pregnancy, it became easier and easier. Like, okay, nothing, nothing's really gone wrong, and I understand a lot of what's going on, and so there were certain moments that were reassuring to me, given my physician background, to um, help with the pregnancy. And then, like I said, it was kind of exciting to be pregnant and relating to my patients in that way as well.
Yeah, that makes a lot of sense. And I remember talking to you a lot about how you were feeling during that pregnancy, and it was something that was exciting because we're friends and we enjoy spending time with each other, and we played board games at each other's houses a lot. Um, but let's talk about sort of what happened. In whatever way that you feel comfortable sharing, I wonder if you could talk about what happened about halfway through pregnancy.
Yeah. So at 23 weeks pregnant, um, I did get sick for about 24 hours and thought nothing of it. And nothing really happened, and it was fine until a few days later, when I was at home and I stood up and my water broke. And as a physician, I was very nervous and I was also a little bit in denial. I was like, no, that can't have been my water. That can't have just happened. But I went in to the OB office and they confirmed that my water had broke. And I recommended that I go to the hospital. At the time, I was in the care of a different hospital system, different health system. But I chose to come to our hospital because I knew the high risk OB group here. And I knew that at 20 weeks and 5 days, I was now in a high risk group of individuals who had had my water prematurely broken. So I came in and was admitted to the hospital. For a few days, I was in the hospital and being monitored. And then day 3 or 4 of being admitted, I started to feel abdominal pain. And again, I was a little bit in denial. Did not realize I was in labor until a few hours into the labor, when the OBs came and checked on me and said, "Oh, your cervix is dilating. The umbilical cord has come through the cervix. What do you want to do next?" And it was a snap decision. I had to have emergency C-section to try to rescue my baby. Um, and so she was born via an emergency C-section. She lived for a few hours in the NICU, during which she coded a few times. And then after or around her third code, we decided not to continue with codes and to transition to comfort care. Um, so then she passed away. Um, and it was, of course, very hard at the time, and it still is very hard. Um, but there's no but to it, really. It's still very hard to lose your child, and it doesn't matter that it was only 24 weeks and 2 days. Um, she still is very much my daughter. Um, but now I do feel like I have a different grasp on obstetrics because I have now been that patient who had a complication. And so I can, in some ways, relate to my patients even better, because those times when things are scary and things aren't the way we planned, I've been there.
One of the reasons why we talked about having this conversation was not to share your story with the podcast audience for no reason, but so that people who are listening could understand a little bit better how to help deal with patients who are going through something like what you went through. And that's a really difficult thing. I remember at the time being your friend, and it was obviously impossibly hard for you. But in a different way, it was hard for me as your friend seeing you go through it and not knowing exactly what the best way was to support you. Now, I remember as sort of people started to find out what had happened, um, our whole department rapidly got behind you and mobilized and got you guys things like food and tried to support you as best we could. Um,
Yeah, I am eternally grateful for all the support that our department has given me and my husband, um, during not only that after that pregnancy, but then with our pregnancy for our next child, because that was very stressful. Everyone has been over the top supportive of us every step of the way and very understanding. Um, and I think that's one of the biggest things is just showing that you care, um, being supportive, um, acknowledging that what your friend or what your patient has gone through is real, and it does hurt. I think some of the hardest things that people said is all related to um oh well, you'll have another kid, or oh well, kind of brushing it under the rug was really hard to go through because I just wanted to be validated, that yes, what I went through was real and it is awful. And it's not just, oh, I'll have another kid. It's that was my kid and I lost it. And sure, I'll have another kid, but that's not what I'm worried about right now is the loss of my current kid. Um, so having that validation of what you're going through is tough and maybe you don't understand how to relate to it and you can't really say, "Oh yeah, even people would say, "Oh, I had this terrible experience during my pregnancy." Nothing like what you went through. And telling me that, saying having that extra thing of like, I understand that like what I went through was hard, but it wasn't losing my child. And so having that validation was very comforting. And then when people didn't validate or they did because it's uncomfortable, try to kind of sweep it under the rug or forget about it or that was actually what hurt the most. And I think it's hard because we don't want to talk about things. Um, One of the reasons I wanted to talk about this is I did have a resident come to me and they were in a C-section with a baby who was not expected to survive. And they said, I had no idea what to say. And I said, well, just being there for them is important. Not saying, not ignoring it, not, it's hard to talk about it. And maybe the mom doesn't want to talk about it, but it also shouldn't be something where you completely ignore what they're going through at that moment. Um, Acknowledging them still as a mom, because I very much identified as a mom. Um, those are all really important things that you can do if you know someone or again know a patient who has gone through that loss, is recognizing that loss. I had a friend who also lost her child at 35 weeks. And we talked about this and she also agreed with me. She said the the biggest thing was just recognizing the elephant in the room. One of the nurses turned to her and said, "Wow, this really sucks." And she said, "Yeah. Yeah, that was really helpful to have someone say, I see what you're going through and it's awful." And it's a silly little thing really, but being that person and saying that, like what you're going through, that's really awful. Um it's extremely interesting how validating that feels and how um, that can actually be helpful because no one wants to say that. No one wants to say, "Wow, this, I'm so sorry that your baby's dying," or that absolutely sucks. Your baby's about to die, or you don't want to say those things, but just s- actually acknowledging that the mom is going through something. And I took that and I used it going forward once I had come back to work, seeing a pregnant patient who had to have um uh basically had a miscarriage um and talking to them and being like, this is really awful and I'm so sorry that you've had to go through this. I know this is a really tough situation for you. And not even saying like, oh, I went through something similar, but just saying this is really really sucky and I'm really sorry that you've been put in this situation. Um and also acknowledging that it's nothing that they did. They've been put in this situation. It's not like, oh, well, if you had done this or oh, well, maybe next time, nothing like that, but just saying this happened to you and I'm sorry it did.
I think that it can be very difficult for patients going through this when they activate the backwards looking part of their brain, thinking to themselves if anything could be different or if things had been different. And I remember having some of those conversations with you, and they were really hard conversations
Yeah.
where we were looking backwards. And the thing that I remember is that at that time it seemed like you had a lot of guilt. And to my eye, that seemed wild to me that you would feel that way. I wonder if you could tell me a little bit more about how you felt and if that's changed now with time and what you think about it.
Yeah, I think it's very easy to feel guilty when a bad outcome happens, especially when you're the parent of a child that passes away. It's easy to say, "Oh, I could have done something." And I think as a physician, especially, we feel like we have a lot of control and understanding over things. But ultimately, we can't change the past for sure. We can look back and they always say hindsight's 2020, but even now, I don't think hindsight's 2020 on this. Um, but you can look back and say, well, I should have done this or I could have done that. And again, the people I know who have lost um, children will say that too. Like, oh, I felt like I could have done this, or maybe I should have gone in sooner, or I should have done this. And there's a lot of could have, should have's, but ultimately it's not anything you did um, that brought this about. Things happen, and it's not anyone's fault. To this day, I still sometimes feel like, oh, could I have done something differently? I don't think that feeling will ever really go away. I can logic that no, like there's nothing I could do differently, but there's that lingering feeling of could have, would have, should have. Um, that doesn't really change. And the best thing you can do is just accept that things happen, and that sometimes there isn't a reason, or maybe next time there's something you would do differently and it's irrational. My second pregnancy, I didn't fly. I don't think it had anything to do with flying, but I had been on a flight less than a week before my water broke. So in my mind, I was like, I'm just not going to fly. It wasn't really harmful to not fly. So why not just do it? Um, and so I think everyone kind of carries those little things with them that um, you can't let it impede your life. But at the same time, if there are little things you do that give you comfort, then that's okay too. The second time I went to the OB emergency department 1 or 2 times, not because anything was wrong, but because I felt odd. And I said, I don't want to feel odd. What if something's happening? And it probably cost me a couple $100, but it did give me the peace of mind of knowing that everything was still going okay. Um, and so there are little things that I changed or did differently, and that probably stemmed from guilt or the thought that maybe I could control or change anything. But ultimately, it really isn't in our control. And trying to accept that can be really hard, but helpful.
I remember talking to you once or twice when you were having some acute anxiety during your second pregnancy with Christopher. And you were trying to ask my opinion about whether or not you should go talk to the OBs and kind of curbside them to maybe get a quick ultrasound done to see what was going on because you maybe felt slightly differently and things like that. And uh, I remember you going on maybe a couple different occasions just to curbside the OBs.
Yeah, helpful bonus to being an OB anesthesiologist is I know the OBs and they know me. And so it was very easy, fortunately, for me to just pop over and say, hey, what do you think of this? Am I being crazy? And sometimes they'd be like, let's just check you out, make sure everything looks okay. Oh, okay, everything looks for great. No big deal. And just having that little curbside it was so helpful because I could, you know, rest assured a little bit that things were going okay.
Do you feel like it made it easier or harder having all of your obstetric knowledge going through pregnancies?
I think in some ways it made it easier because there were things that I understood um, that were helpful to me going through my pregnancies. Um, Things I understood about odds and after I did have my water break, what that might look like. Having seen patients go through that as well. Um, Having an idea as to what I was when I chose to have an emergency C-section to try to save my daughter, I knew very well what I was going into. I was about to have a major abdominal surgery, and because I was so early on, I was going to have no choice but to have C-sections for all future pregnancies. And some people don't know what that means, but I've been through OB enough that I knew exactly what I was accepting as a risk in order to try to get my daughter out so she could live. Um, and maybe if I didn't have that knowledge, I would have still made that decision. But I at least went in with my eyes open as to what exactly the risks I was accepting with that. So in some ways, it was helpful. And in other ways, it was more terrifying. Like when they told me in the OB office, yeah, your water broke, I started crying immediately. And they were like, we haven't even really told you what that means. Why are you freaking out? But I had seen enough patients
You knew what it
that
meant.
I knew exactly what it meant and I knew what the road ahead of me looked like. And so helpful, but also not because my anxiety level was probably higher than the average person who was told their water broke. Um, and I think also it gave me a false sense of control. So I was in the hospital and I would, something would happen. I was starting to feel pain. I'm like, this can't be labor. I know what labor looks like. It was labor, but I thought I knew. I didn't. I'd never been through it before. I don't know why I thought that having seen it, I would then know what it felt like. Um, so I think it kind of goes both ways.
I remember a very distinct point in your second pregnancy with Christopher where you got to the same length of time in your pregnancy that you did when you had Alice. Was that reassuring to get past that point? Can you describe what your feelings were around that time?
So 24 weeks was very hard on me when I was pregnant with my second because I had lost Alice at 24 weeks and 2 days. I had ruptured at 23 and 5 days. So those 4 days were very anxiety provoking for me because could it happen again? Logically, it wouldn't happen at the same exact time. That would be really, really odd. But there is something inside you that says, oh my gosh, this could happen again. And this is the moment that it did happen before. Could it happen again? Once I got to 25 weeks, it was reassuring because I had never made it that far in pregnancy before. And so there was a sigh of relief of, okay, I have made it to 25 weeks. And again, being an OB anesthesia and having worked a little bit in the NICU, I knew what the difference between a 24-week baby and a 25-week baby was. And so it was reassuring from that standpoint too, that if he was born now, he at least had a better chance of survival than my baby at 24 and 2. So even if it did happen again, we had made it further and there was a better chance that he was going to um, have um, a more positive outcome. So,
I remember when you came back, um, you had a tough time coming back to work on OB, which I think made a lot of sense. I think that there was likely some component of PTSD associated with that. But over time, you sort of eased yourself back into working in OB. That's what you did your fellowship in, and you're quite good at it. I wonder if you could talk about how you overcame that to a degree and how you feel working in OB now.
I did take a little bit of time coming back to OB. Um, I think, as you mentioned, having been through everything, PTSD would be normal, and we don't always normalize it, but it would be a normal response to what I went through. I think the major reason I didn't go back to OB right away is I did not want my experiences to impact my patients' experiences. I did not want to be in a delivery and start crying, and they're like, "But my baby's fine. What are you doing?"
Sure.
Because of how recent my experiences had been. But over time, that became easier to do. And it's something I really do have a passion for and love. So it's not something I would ever really plan on leaving behind or letting the fear or emotions associated with my experiences impact um, my career as an OB anesthesiologist. Over time, it became easier too to shift my experiences into positive outcomes for other patients. Not positive outcomes in terms of like, I was going to help their babies do better or anything like that, but have their experiences be impacted positively by my experiences. And so that was important to me too, that I could use my experiences to help others as they went through similar experiences.
What do you think are some of your best pieces of advice for how to approach friends and colleagues that might be going through a situation like what you went through?
Absolutely. I think anyone who has been in the situation would hopefully agree that time doesn't heal all wounds. Um, I wish I could tell you that at some point it is what it is. It's the past. Maybe you're more willing to talk about it. Maybe you can turn the situation into more positive things like helping others with what you've been through. And that's amazing and important. But to this day, I still think of my daughter. That never goes away and it can sneak up on you in different moments. And that's okay and that's normal. Everyone grieves differently. Everyone has different experiences when it comes to losing someone they love. And just because you are different from your spouse, are different from your mother, are different from siblings, everyone experiences the loss, but everyone experiences it differently. And it doesn't mean you're different or grieving wrong. Everyone grieves differently. And understanding that is important. And trying to understand where other people are coming from in their grief, because you're not the only one grieving when you've gone through a loss. The people around you are grieving with you, and they might show their grief in different ways. And that's important too. Um, that you all recognize your grief and then recognize other people's grief as well. Uh, I think those are the biggest things I would want someone to take away, that people grieve differently, different timelines. You never stop truly grieving, but it just looks differently. And sometimes you can turn it into helping others.
What should friends do if they want to help, but they are afraid of saying the wrong thing?
I think that's a fear that a lot of people have when they have someone, a friend, family member going through a loss. And again, I think it's hard to say things like, so sorry for your loss, or to bring it up. You don't want them to, if they're not talking about it, you don't want to bring it on them so that they are thinking about it. I can tell you they're thinking about it, whether they're talking about it or not. And so, just as I mentioned earlier about reading each patient, reading your friend and seeing what they need most. And sometimes it's a hug and some silence. And sometimes it's saying, that really, really sucked. Or sometimes it's lending an ear and being like, tell me about it. Because I don't know what you're going through or don't know what you went through. Sometimes it's just very simply addressing it, saying, I'm so sorry that that happened. But I think as a society, we just kind of ignore it or we push it under the rug or we want to talk about other things. And I think there's a lot of things that you can say, and maybe some people will take it the right way and some people will take it the wrong way. But I think just saying something or being there is one of the biggest things, and not ignoring it or brushing it under the rug or um, saying, "Oh well, but at least this is true," or trying to look on the bright side because maybe they don't want to look at the bright side right now, and that's okay. If they want to look on the bright side and they say at least that, you can agree with them. But but um, I think that's important as a friend, just to be there for them as in whatever way that looks like. Bring them a book to read or a meal you made, or again, just sitting there or listening. You don't have to say anything, but just being there.
Lastly, I want to wrap up with the question about what your style points are or what your points of personal preference are that help you on OB anesthesia or just generally in life. Um, what what do you want to leave us with today?
I think one of the great privileges of our job is to be there for patients, whether it be on OB or in the main operating room or whatever environment you're in as an anesthesiologist, being there for patients during a time of need and recognizing that, recognizing the situation they're in, helping them through it, telling them that you'll be there, being a, a confident supporter of them, letting them know that you see them as a person. These are all amazing things we can do to help our patients through the day. And I think that also extends into life when you see your friends or your colleagues going through something, listening, being there for them. Even little things can make a huge difference in someone's day, be it a patient, you compliment them on their nails, or your friend, you just listen to them talk about how terrible their weekend was, or what have you. Being there for each other is a wonderful privilege that we have as anesthesiologists, but then also that we carry over into life.
Mary, thank you for sharing your beautiful voice with us.
Thank you for having me.
That's it for this episode of Style Points. I talked to Mary for a while about this episode. She told me that if anyone is listening who wants to reach out and talk to her about what we discussed in the episode, she's happy to talk to you. If you'd like to help other people find the podcast, please feel free to leave us a rating or a written review. That's the number one thing that will help other people find the show. You can also contact me at stylepointspodcast@gmail.com. Take a deep breath. Open your eyes. We're all done.